Good afternoon. I'm Jeremy Patch, Director of Patient Programs and Education here at Zero Prostate Cancer. Thank you for joining us for today's discussion. I'm joined by Dr. Benjamin Maughan, an Assistant Professor in the Division of Medical Oncology at Huntsman Cancer Institute in Utah. Dr. Maughan is here to give us more information on chemotherapy and when it might be right as a treatment option for prostate cancer. Welcome, Dr. Maughan.
Thank you so much, Jeremy. It's wonderful to be here with you. I have just the greatest admiration for the vision of the Zero Foundation and what you're trying to accomplish. So I'm honored to be here with you today.
Thank you. Great. Dr. Maughan, let's get into it. Thanks for joining us. Chemotherapy is typically used to treat advanced prostate cancer, as we know. Which advanced patients might be good candidates for chemotherapy?
Yeah, that's I think the first question that a lot of people think of when at least when I see new patients with prostate cancer, that's one of the first questions they have is chemotherapy, the right thing for me? Are there other alternatives to chemotherapy? So that's like front and center with at least a lot of the patients I treat. So as sort of a very brief explanation, I think for the context of this question and discussion, it's, I think, helpful to define what advanced prostate cancer means. And at least in my mind, when people talk about this phrase, advanced prostate cancer, it's referring to a patient that's in a situation where curative intent treatment like surgery or radiation is not applicable for a variety of reasons. So anyway, for patients with advanced prostate cancer, the sort of backbone of treatment in terms of disease control, because that's the focus then of the therapies that we have, is to try and control the disease. The backbone of treatment is hormone-based therapy. And sometimes we add into that hormone therapy things like chemotherapy. So sometimes we do it at the very beginning of their treatment, and sometimes we wait and do it later on in their treatment. But it is a consideration for most patients that have advanced prostate cancer somewhere along the time of their treatment continuum.
That's good to know. Thank you. At what point do advanced prostate cancer patients typically receive chemotherapy? So, for example, is it a first line, second line, third line of treatment?
Yeah, so excuse me. Even though it can be considered technically at any point along the treatment spectrum, so their very first treatment, sometimes referred to as a first-line therapy, or second, third, fourth, fifth, whatever line of therapy. Most commonly in the United States, at least, most commonly it's reserved for later on in the treatment sequence. It doesn't always have to be given that way. There are reasons to consider doing it earlier on in the treatment sequence. But if you look at practice patterns across the United States, it's most commonly reserved for later on in the treatment sequence. But again, so typically we're talking about something more like, third, fourth line therapy. My own practice, I tend to use it a little more, early on in the treatment sequence than, what we see, listed in the, sort of practice pattern, data, but it's typically not the first or second therapy that's chosen.
And is chemotherapy given by itself or in combination with other treatments typically?
Yeah, so technically it's always given in combination, because for patients that have advanced or incurable prostate cancer, the sort of baseline foundation of treatment that we always do is something called androgen deprivation therapy, or sometimes truncated to the acronym ADT. So ADT is just a term that means in some way, either doing surgery or medicines, we're trying to block the testicles from producing testosterone. And that's where most of the testosterone is made. Not all, but the majority of the testosterone in the body is made from the testicles. So that's a component that we sort of start at the beginning. and then continue throughout the patient's life. And then in addition to that, we add in other therapies. Now, the other things that we add in, those aren't permanent like the ADT typically is. These other things we'll use as long as they work, and when they stop working, you stop them and replace them with something else. So technically, chemotherapy is always given in combination because it's given in combination with ADT. But I think to your point, sort of ignoring the ADT because it's always sort of there in the background, do we give chemotherapy in combination with other treatments? And the answer is yes, sometimes. So I guess technically it's yes and no. Most commonly it's no, though. The patients that we give chemotherapy in combination with other stuff is patients that have more aggressive disease than average. I mean, we're talking about advanced prostate cancer, so by definition, everyone has sort of aggressive disease, but if you sort of look at that population as the whole, the patients that receive sort of chemotherapy in combination with other things beyond ADT have even more aggressive disease than you typically see.
We've discussed chemotherapy so far as an option for advanced prostate cancer patients, but is chemotherapy an option for early stage prostate cancer? And if so, for whom?
Yeah, this actually is a question that's been around for quite some time and has resulted in a number of different large phase 3 clinical trials. So we do know that there are differences between every person's prostate cancer. Relatively speaking, some patients' prostate cancer is more aggressive and other patients' prostate cancer is less aggressive. So of those patients that have localized prostate cancer, right? So we're thinking about their disease in the curative context. We're unfortunately not able to cure all those patients, but that's how we're conceiving the treatment for that individual. So for patients that have localized prostate cancer, we know that some patients have features that suggest either sort of relatively advanced disease, considering it's localized, or it's biologically particularly aggressive. Like, for instance, if it has a high Gleason score, especially like a Gleason grade group, 4 or especially 5. The other way that that's reported is like in the separate numbers. So for patients that have like Gleason 4+5 or 5+4 or 5+5, if they have lymph nodes, pelvic lymph nodes that are involved in their prostate cancer. Sometimes we have other pathologic criteria, like if they've got ductal features or if they've had surgery and they've got positive margins. Anyway, a lot of these things suggest more advanced disease. There are adjuvant treatments that have been tested, so treatments given after the time of surgery or after the time of radiation. And at times those studies have included chemotherapy. These trials have not shown an improvement in overall survival, meaning they're not curing more patients. They consistently seem to prolong the time until it comes back and sort of intermediate endpoints or goals like that. But in terms of curing more patients, they don't seem to consistently be able to achieve that outcome. So at this day and age, they're not, chemotherapy is typically not given for patients with any degree of locally advanced prostate cancer. Again, it's reserved for patients that have advanced or incurable prostate cancer.
Thank you. There are different types of chemo available, such as taxane and platinum chemotherapies, and we want to make sure everyone understands the difference. What types are used to treat prostate cancer?
Yeah, so chemotherapy is sort of a broad-based word, really, that just means you have a fairly toxic compound that in some way is damaging the DNA or the molecular machinery of the cell. So think of it like a poison. It's particularly toxic typically for fast-growing cells, right? And cancer cells grow fast. But there's different types of chemotherapy because they work in slightly different ways. So there's been a number of different types of chemotherapy over the years tested in prostate cancer, particularly in the 80s, 90s, and some a little bit in the early 2000s. The two types of chemotherapy classes or mechanisms that seem to consistently provide significant clinical benefit for patients include this category we call taxanes. So the two that are FDA approved today in this class include docetaxel and cabazitaxel. And it technically isn't FDA approved, but this other class called platinum therapy, it's been demonstrated in multiple clinical trials, and it's on a lot of guideline body recommendations like ASCO and ESMO and NCCN. The platinum-based therapies can be used for those patients who have particularly very aggressive prostate cancer. But by and large, the chemotherapy we're talking about that patients receive are these taxane-based chemotherapy drugs. And the time of when we give these, again, sometimes patients receive them as their very first therapy. In that situation, it's docetaxel that we're referring to. But more commonly, patients are receiving them later on in their treatment sequence, like second or especially third or fourth line therapy. And typically, based on a couple of different clinical trials, we found that sequencing these two drugs seems to maximize their benefits. So typically, patients are started with docetaxel, and then sometime after their cancer becomes resistant, maybe it's the very next treatment they go to, or maybe it's something else in between. But after, progressing on docetaxel, then they proceed and try cabazitaxel.
We often hear from patients that they dread the side effects of chemotherapy. Are the side effects as bad as some fear? What is typical, and how can the side effects be managed?
That's I think a really fabulous question. So I think, in my opinion, the best answer to the first part of the question is no. I think most patients have an overly healthy fear of chemotherapy relative to what they actually experience. And I think that's in part because, again, there's a lot of different types of classes and specific drugs of chemotherapy, and many of them don't work for prostate cancer. Of the ones that do, they tend to be on the much better tolerated, space of the chemotherapy spectrum. Clearly, there are definitely some chemotherapy drugs that we use for other cancers that are really difficult to tolerate. They cause a lot of problems. You can think of combinations, especially that we use for things like acute leukemia, or even certain like pancreatic cancers and others that are very difficult to tolerate, germ cell cancers. But in part because we don't tend to use combination chemotherapy for prostate cancer, these are much better tolerated. But even the individual chemotherapy drugs themselves that we use, again, are also much better tolerated than other individual chemotherapy drugs we use for other situations. The types of problems that these taxane chemotherapy drugs cause include, and remember, this includes both docetaxel and cabazitaxel. The sort of shared toxicity they both cause is tiredness and fatigue. The other problem that is shared that, between these two chemotherapy drugs is what we call cytopenias, or reduction in the blood counts. The bone marrow, where the blood cells are made, like red blood cells, the infection-fighting white blood cells, and platelets, the bone marrow is where these cells are produced, and the bone marrow stem cells turn over very quickly, which is why they're also affected by chemotherapy. So those are sort of the shared toxicities between these two. In addition to that, docetaxel, actually, even though we use it first, tends to be somewhat less well tolerated than cabazitaxel, and it has some additional toxicities on top of that. And it includes neuropathies, meaning there's nerve injury. This is most commonly experienced as some type of deleterious or negative sensation to the hands and feet, like pain or numbness or burning. It can also cause other types of neuropathy, but the sensory neuropathy to the hands and feet is the most common. Like it can affect the hearing, or sometimes it can affect the nerves that are involved with like balance or whatever. But the most common is sensory autonomic neuropathy or sensory neuropathy. And it can also cause hair loss. The hair loss is reversible. So once the chemotherapy is finished, then the hair starts growing again. Now, these latter two problems of neuropathy and hair loss really are only consequences of the docetaxel, and we don't tend to see them with the cabazitaxel. So the latter part of your question was, how do we better manage this? So the fatigue, that is really a dose-related phenomenon. So the more, doses that a patient has, or sometimes we call them cycles, the more doses or cycles they have, the more this sort of fatigue builds up. So the way to manage that is with managing the doses. So sometimes we reduce the amount of chemotherapy that a patient gets. Sometimes we pause the chemotherapy and give them a break. And then that helps the fatigue improve. But that's really dependent on the chemotherapy drug itself. Being active, physically active, helps mitigate this a little bit, but mostly it's just related to the drug exposure. The hair loss is just something that there's not much to be done there. It just kind of happens. In terms of the infections and the other blood counts, this is also a function of the drug exposure. So we can help manage the, anemia, for instance, by reducing the amount of drug that's given with each dose, or we can limit the number of doses that are given, or we can take pauses between the doses. And then sometimes we also give medicines that stimulate the white blood cells, and the purpose of this is to reduce the risk of infections. But a lot of these toxicities or side effects are managed based on the drug exposure itself. Now, notably, hopefully, one thing you noticed, Jeremy, that I did not talk about was nausea and vomiting. Neither of these drugs really cause much nausea or vomiting from my personal experience, and indeed also that the information that we see published from the prostate cancer chemotherapy clinical trials, only a very small proportion of men have nausea. Really, nobody, very, very infrequently has vomiting at all with these medicines. If that is a problem for the rare occasional patient, that's, again, from my experience, easily managed by just giving them some sort of prophylactic or abortive medicines like Zofran. But I give all my patients Zofran so that they can have it at home in case they need it, but almost nobody ever uses it. These medicines really don't cause nausea or vomiting in any significant degree.
Okay, that was a helpful rundown of the side effects and how they can be managed, and some positive news that it's not as bad sometimes, at least for prostate cancer patients, it sounds like, as some other cancers.
Now I will say there's been a number of studies now, large studies, that have compared the quality of life between patients on just hormone therapy, right? So, they're on ADT, for instance, plus some other hormone pill, or they're on ADT plus chemotherapy with like docetaxel. And we do see that the quality of life, is measured by, fatigue or, just how well the patient feels. Consistently, the quality of life is somewhat better with the non-chemotherapy options compared to the chemotherapy options. So there are some side effects that are sort of greater or experienced more frequently with chemotherapy-based treatment compared to non-chemotherapy-based treatment. But I guess a couple of comments that I have in regards to that information is that, one, the difference between those groups with chemotherapy versus without is not particularly huge. So chemotherapy only causes slightly worse quality of life impacts. But the other sort of observation of that is, because of that sort of information and knowledge, that's one of the reasons that frequently chemotherapy is deferred later. It's not used as early in the treatment.
To wrap up, what's your best advice for patients who are candidates for chemotherapy and are considering it as a treatment option?
Yeah, so I guess my best advice would be, I think it's always helpful to talk to other prostate cancer patients that have been through it before, to really get a good feel, I mean, as best as you can, of what it's like and how much it has or has not impacted those individuals. But I guess I would also like to give some encouragement that it's not nearly as difficult to go through as you oftentimes see portrayed on TV. They're like looking all awful and they're barely pushing an IV pole down the hallway and the lights are all dim. And certainly some patients can have a very rough go with chemotherapy like that, for other cancers with other types of chemotherapy, but that's not really what we see with these drugs that we use for prostate cancer. So, in the right setting, these can be very effective drugs to really help us maintain a patient's meaningful quality of life and obtain good, durable disease control. So
That's good to hear. And I will, put a plug in. You said talk to other patients. I'm going to put a plug in for our support groups that we offer through Zero, as well as we have our mentor program, which is a one-to-one peer matching program. So talking to other patients can help. So that's good to hear. Well, thank
yeah,
you,
I'll
Dr.
definitely echo
Maughan.
that, especially in this era of like Zoom, et cetera, that we're doing.
Right.
I've had so many patients that have been able to utilize the resources of your organization, others, to really help them navigate this difficult time. So these resources that your organization offers are just fantastic, and I too would echo all the patients to utilize them.
Well, thank you, Dr. Maughan, for this great discussion. We appreciate you providing your time and expertise to Zero and our patient community. Thank you also to Sanofi, the sponsor of this event. We encourage all of you to go to our website to learn more about chemotherapy, including a guide and our Questions for Your Doctor series focused on chemo. Thanks again for watching. Have a great day.